You were sharing a story, and it made me think that I wanted to share a story earlier when we were talking about, when you're saying, how do you know when there's a fracture of an ankle versus a sprain? And I just recently, this isn't a HIPAA violation because it's about my
Okay.
mom. It's about my mom, and I'm sure she's okay with me sharing the
Did she
story.
give you permission to share this story,
I'll
young
get her to
man?
sign a release before you put this episode out.
Welcome, everybody, to the first official episode of the JAFERD cast. I am your host, Dr. Mark Pappadakis. Nobody in particular, just another fucking ER doctor. For this episode, we're going to be talking with Dr. Jared Pastor. He's a sports medicine trained physician and one of my colleagues who I'm proud to work with in the emergency department. He's going to be talking about sprains, fractures, physical therapy, when to seek the ER versus urgent care for these types of injuries. So it's going to be a pretty good time. So let's get him in here. All right, so I'm here with our guest for this show, Dr. Jared Pastor. Jared, welcome to the JAFERD cast. Great to have you here.
Thank you. I appreciate it. Thanks for having me.
So I know you're sports medicine, but tell me about yourself. Tell me, what do you do, where you train, etc.
Sure. So I did a fellowship in sports medicine, but my primary training is emergency medicine. I was a non-traditional student, actually. I had a career prior to medical school. I did,
Ah,
it's called intraoperative monitoring or neurophysiology, and I actually did that for almost a decade. And then I decided that I wanted to go back to medical school.
I didn't even know that.
Well, yeah. Actually, the same hospital we work at now is where I did my first career, so
Oh, shit.
everything came full circle. Yeah,
And they
it's
hired you
pretty great.
back. Look at
I
that.
am, believe it or
That's
not.
impressive.
But yeah, but I wasn't pre-med initially, so I had to go back and do, all the pre-med courses. I did a
Mm.
post-bac, I did a master's program up at Rutgers, my medical school at Rowan SOM in South Jersey,
Wow.
emergency medicine training at St. Luke's in Bethlehem, and then my
Oh,
sports
yeah.
medicine at Lehigh Valley, right next to St. Luke's.
Awesome. I actually applied to Lehigh Valley. They rejected me. So, it's
They're
fine.
lost. They're lost.
That's right. So tell me about what's sports medicine? What does sports medicine entail?
My training in sports medicine it's basically primary care sports medicine or non-operative orthopedics. So
Mm.
I'm not in the operating room. I manage any kind of ailments or injuries, musculoskeletal things that, to be simplified, don't require surgery.
Okay. So, do you refer out to specialists who do surgery? Is it a solo practice? How does that work for you? Because you're
Yeah,
also emergency medicine. Like, you're also, clinically,
yeah.
you're in with me in the ER doing this stuff. So, how does that kind of work?
Yeah, I have a unique balance of the two of them. That's the beauty of doing a fellowship. You could fully commit to it, and that could be your full-time job, or you can do
Mm.
it part-time. And I'm doing it part-time. So the way I'm doing my specialty training, as you know, I am full-time
Mm-hmm.
emergency medicine, and then I do some part-time sports medicine on top of that. So we have a clinic run through one of the residency programs here where we do a twice a month clinic. I'll see any type of really non-operative orthopedics. And if
Mm.
anything needs surgery, because sometimes it will come to me
Mm-hmm.
and really need a specialist, yes, I will absolutely refer out to the orthopedic surgeon or whatever specialist is needed to manage that
Do you
patient.
do you have connections? Like, do the orthopedic surgeons know you? Do they know about this clinic? How did that kind of get off the ground?
Some of them do, but it's completely separate from our orthopedic surgeons at our hospital. It's not, I don't work with them. They are, we use
Mm.
private practice groups. I am not part of a
Mm.
private practice group. I am hospital employed. So I am working through a residency, and some of the orthopedic surgeons also have their own clinics, and we have an overlap with patients, and they know of me, but we don't have the same employer technically.
Gotcha. Yeah. All right. So, what are the most common? What are the more common things that you see come into your clinic? Complaints, common referrals. What do you normally see?
A lot of it is osteoarthritis. That's really,
Mm.
a lot of bread and butter of the orthopedic world is wear and tear and osteoarthritic pain, knee pain, shoulder pain. But I'll see a large variety of things. I'll see, the younger person with foot pain, younger
Mm.
people with elbow pain, shoulder pain, osteoarthritis, minor injuries of the rotator cuff, anything like that.
So, are you kind of like a emergency medicine, right? Like, we see people coming in, pain for 2 weeks, 3 months, whatever the case is. Do you get these people, and have they had like follow up beforehand? Are they kind of at their wits end? Like, what ends up happening here?
Yeah. So It has to be referred to me. Nobody is
Right.
coming, at least yet. We don't have it set up where they come
So
directly to
you
me
have a
on
big
their own.
sign out the front that basically says, hey, sports medicine here, please come to me. Not yet.
Right. Not yet. We'll get
Okay.
there. But right now, it's all referrals. So it's either from the emergency department or more likely from a primary care doctor or
Okay.
somebody that saw them initially that is in the same practice that thinks they would benefit from sports medicine as opposed to, let's say, rheumatology or pain
Mm.
management or even just going directly to the orthopedic surgeon if they're pretty confident whatever they're dealing with needs surgical repair.
Osteoarthritis is obviously a big thing that we see in the emergency department. And these are people who I've even seen some younger people lately come in, but it's mostly related from either a high school athlete, college athlete that, their bodies kind of got worn down from that. And now they're paying the price a little bit. What is osteoarthritis? Like, like they hear the term and, they say, oh, well, the doctor says I have bone on bone. And it's like, yeah,
Yeah.
that's osteoarthritis.
That's really how I explain it to patients. I don't get overly involved in like all the metabolic things that are going on, but it's a wear and
Mm,
tear of your joint. And it's funny you say bone on bone because I try not to use that
mm,
language with patients only because I feel like we underestimate how much power we have in our words to patients, and the second you say something like that, like your bones look horrible, your bone on bone,
mm,
I think it scares some patients away from being active and walking and exercising and they look at it the wrong way and really even if you are bone on bone and your x-rays look horrible if you're not very symptomatic we don't need to do anything about it you know things
So
are going to
if
happen over time that doesn't necessarily need to be intervened on if it's not really
right.
interfering with your life or if your symptoms are mild.
Right. Now, one of the recommendations you guys give is physical therapy, but it seems like an oxymoron. Like if you have somebody comes in and they have joint pain, they have knee pain, they have back pain, whatever, and you tell them, oh, it's just for, wear and tear. Isn't it kind of weird you're telling them, hey, go out there and do some more wear and tear with physical therapy? Like, how does that really
Yeah.
work here?
Yeah, well, that's exactly it. And that's why you have to be careful with the words you use, because when you say it that way and they misinterpret it or they think you're saying, oh, so I need to use everything less because every time
Mm-hmm.
I do more, I'm going to wear it away and my symptoms are going to get worse. When that's not the truth. Like I said, it's a lot more
Mm.
complex process than just wear and tear, but
I'm
this
drinking
is
some
kind of a,
coffee, so
sure.
please continue.
Yeah. But
Oh,
honestly, the worst thing you can do in general is to just stop moving. Even these people that have wear and tear of their joints benefit from
mm-hmm.
exercise. They benefit from strengthening muscles around that joint. They benefit from learning what they're potentially doing that's exacerbating their symptoms, because some movements are good movements, some movements are bad movements. Sometimes you have some asymmetry of your certain muscle groups, and that physical therapy is very helpful for these people, especially the ones that don't
So
have that
basically, you're
foundation
not,
knowledge.
the therapy isn't directed at the joint that's the problem. It's more directed at the things around the joint that says, look, we can make this stronger so you use that joint less. Or you're, hey, picking up your 19-month-old is probably a problem for your back spasm, so let's teach you how to do something different instead.
Sure. Yeah, and I don't want to speak for physical therapists, but yeah, that is a lot of what
Sure.
they do is and making sure, what movements are you doing that are potentially exacerbating your symptoms? Are you lifting things the wrong way? Is your gait off? Could you work on muscle? Yes, maybe it's the knee where you're having pain, but maybe it's issues with your hips or your feet that are contributing to your underlying knee
Mm-hmm.
pain.
I want to switch gears a little bit. So, one of the part of the more common things that I refer to you guys for from the ER is like simple sprains, fractures, things like that. Can you talk a little bit about a sprain versus a fracture? I get somebody that says, "Oh, I rolled my ankle and, I think I heard a pop. I think it's fractured, and they come to me, really come to us, really, let's get an x-ray. Can you tell on your exam or whatever without an x-ray first of all, yeah, you have a fracture or, nah, I think you're okay.
Oftentimes we can, yes. What was the mechanism of injury? Where is your injury? How bad was it? What did you hear? Certainly somebody says those keywords of, oh, I heard a snap, I heard a crack. You get more concerned for a fracture. But yeah, there are even clinical guidelines that we use for, you brought up ankle. Ankle injuries are very common. People sprain their
Mm,
ankles or twist their ankles all the time. And that's the question. Did I break something? Did I sprain it? And there's criteria we use called like the Ottawa ankle rules. So every medical student learns about that. And it's certain criteria that we use to determine is this injury something that would benefit from an X-ray to rule out a fracture. So yeah, absolutely. There are lots of times we can clinically tell that something is far more likely to be a sprain than a fracture.
So can the average person tell? Let me ask you that one. Do you think the average person can tell sprain or fracture? So to preface, let's say somebody rolled their ankle in jiu-jitsu. I'm not naming names. Let's say somebody rolled their ankle and then, all of a sudden, they say, okay, well, I probably just sprained it, and all of a sudden it swells up. Right now it's looking purple, this and that. They're like, I think I fractured it. Now what? Is that this swelling indication? Is it the nature of the injury? Like, how are they supposed to know? Yeah, I think it's broken.
Sure. Yeah. Honestly, especially nowadays, it's you can look up something like the Ottawa ankle rules. The question is you have to know that exists to begin with. You could ask ChatGPT and get some information from it, I'm sure. But I guess a big takeaway is if you don't know, be seen by a professional. Go to your primary doctor. As long as the injury seems relatively minor, you're able to ambulate, you're just seeing some swelling and redness. If you're not sure, you can go to an urgent care. And if you have major red flag symptoms, so if you're having the worst pain of your life, you can't bear weight at all, you see bone protruding from the skin.
I would say that would probably be a big thing. If all of a sudden I see a bone sticking up out of my elbow, I probably want to go to the ER, not an urgent care.
Correct. Yeah, the red flag symptoms like that, go to the emergency department. Absolutely.
What types of fractures are you most concerned about? Like, let's say you get somebody that says, all right, I fractured my elbow, I have an ankle fracture. You see them in your clinic, right? And you say, okay, you know what? It's not that big of a deal. We'll just kind of watch it and do nothing. Basically, here's some pain meds, rest it, we're done. How do you approach, what fractures do you approach that way?
Generally speaking, in fractures, the vast majority of fractures do not need surgery. Something like 80 or 90% of fractures that occur.
Well, that's pretty freaking high. That's actually higher than I thought.
If you take all fractures into consideration, but it's very dependent. It's dependent on multiple things, but like where is your fracture? How much pain are you having? How much function are you losing from this fracture? So it's not just where the fracture is, it's also who is the person that had the fracture. A fracture in an older person may be managed much different than a younger one, and one in an athlete may be treated much differently than a non-athlete. And not even just fractures, things like ACL tears are going to be more aggressive to treat in an athlete that wants to get back to playing sports than we potentially would somebody older who doesn't need as much function with their knee and can kind of give it more time to heal on its own.
So I was going to say, so there's a difference between, when we say athlete, we're talking like your professional baseball, football player, star athlete out there, even, maybe the minors. Maybe a minor athlete would do it. But somebody like, who's in college, let's say. Like, let's say they're 19, 20 years old and they're on a college scholarship. Are they going to be treated to the same degree as a professional athlete in terms of surgical needs, imaging?
They should, yeah. I mean, it's all dependent on your goals. Right? And it'll be individualized. Somebody may say, I don't care that much about whatever football, baseball. I don't want to go through the surgery and the recovery. And it's, tough to go through that. And it's a lot of work and a lot of effort. And it is still individualized. But yeah, if your goal is to get back to sports as your passion, it doesn't matter if you're a professional or an amateur. If that's what makes you happy and that's your lifestyle, yeah, you should be treated the same way and you should have the same options for surgery.
Does pickleball count as a sport that you may be passionate about? Like, if you get somebody that says, you know what, look, I have a pickleball, twice a week with my friends, I got to get back on that court.
Believe it or not, I have yet to play pickleball. I wanted to so bad because everybody talks about it.
Okay, well, you're behind the times.
I am.
All right.
Really am. But yes, yeah, if that what makes you happy and you know that not being able to play pickleball and getting back to the lifestyle that you want, then sure, yeah, then that is taken into consideration to if your potential injury would benefit from surgery.
So what's recovery looking like? Let's kind of break it down between sprain and fracture. So you have a sprain, let's say you have a common one is an ankle sprain. You sprained your ankle. How long are you going to be, on your ass, on bed? How long are you going to be out of work, etc.?
So it varies because there are different types of sprains. Every sprain is not created equally. So you can have a minor sprain, you could have a severe sprain. A minor sprain, so like a minor tear of a ligament, could really take 1 or 2 weeks of recovery, and we want you right back on your feet.
That long?
Like a suit.
Yeah. Well, I mean, ideally, yeah.
I said
but it's kind of like, okay, I'm going to say like, oh, well, can we, be on my feet in like a couple days? Like, probably not. It's going to take.
Well, so You can be on your feet. Like you don't need to be immobile for that period of time.
Okay.
I didn't mean to misspeak if I said that. And generally speaking, we're talking about sprains right now. So like a minor
Sure.
ankle
Yeah, yeah.
sprain, your goal should be to get back on your feet as soon as possible. You don't want to be completely immobile. You don't want to uh, just have your leg up 24/7.
Yeah, but it
You want
hurts.
to get,
Why the hell do I want
yeah.
to walk on something that hurts me
uh,
all the time?
yeah, I mean that's a great question, and people will avoid it, but that helps speed up recovery. There's good data that the quicker we get back to, and again, there are extremes to this, right? So you shouldn't go back to lifting,
Mm.
you're trying to get like your 1 rep max in or anything, right? I mean, in the process of recovering, but slowly getting back and putting pressure on your foot and doing small exercises and range of motion, that is encouraged as quickly as possible without pushing it. Nothing should make your symptoms worse. So you
Okay.
shouldn't be doing things and pushing through it and being like, okay, the more it hurts, the faster I'm recovering. That's not the
No
point I'm
pain,
trying
no
to make.
gain.
Yeah, yeah. No,
That's just that's the old
I
adage.
don't prescribe to that necessarily, but I know I keep saying it over and over. Movement is good. Like getting your body back into to exercising and walking and moving is always a good thing, and you want to do that as soon as possible.
Now, what about fractures? So let's say non-surgical. You fractured an elbow. Cracked an ankle bone somewhere. Now what?
So again, it very much depends on where the fracture is, and what type of fracture it is. There are stress
There's only two
fractures.
fractures, right? Broken and not broken. That's
Yeah, right. Fractured or broken. No, I mean, there are small fractures, there are
mm.
displaced fractures, there are comminuted fractures, there are
so.
stress
So
fractures,
continuity means they're just like
multiple
bone
fragments
on
of
bone, like
fracture,
actual bone
right?
on bone.
Yeah, so there are just like there are degrees to sprains, there's the same with fractures, and the location of the fracture matters too. So breaking like your pinky toe wouldn't necessarily be treated the same way as if you were to break your femur. And those are the two extremes. But
That would suck.
yeah,
We've seen that.
oh,
We've seen a few femur
we see that a
fractures.
ton, and that's a good example of somewhere where your femur, which is the large bone in your leg that connects to your hip, we see a lot of femoral neck fractures, and that is a
Mm-hmm.
weight-bearing area of your body. But those almost always are surgical,
Mm-hmm.
because you can't, like I was saying earlier with minor sprains, you want to get back on your feet as soon as possible. You can't do that with a femoral neck fracture. You will delay
Right.
healing in that case, and you won't be able to walk to begin with. So for lifestyle purposes, for healing purposes, those are surgery pretty much always.
And there's concerns too about not just the bone itself that's a problem, but also we're talking about blood vessels, nerves. I mean, people don't understand that bones are not just sitting in your body in a vacuum either. You have nerves that wrap around them, you have blood vessels that go in and out of them. So you break certain long bones, and the femur is a long bone, humerus, whatever. Now suddenly you're compromising these nerves. You can get things like weakness, joint weakness, ischemia, which is basically like a lack of blood flow somewhere, and that's bad. So people who are ambulating on like a femur fracture, a hip fracture, it's not just they delay their own healing; they can actually do much more damage too, and not realize it.
Yeah, correct. Which is why, like you said, how can patients know if they need to manage something on their own versus seeing a specialist? And those are reasons why you should see a sports medicine doctor or your primary doctor or an orthopedic surgeon so they can guide you in this process. When is it okay to use this broken bone? When is it okay to get back on the sprain? Because I am generalizing a lot here, and I don't want people
Oh
to
yeah,
think, cool, I broke my arm, I should go back to lifting the next day. It's not
right.
that
Yeah.
straightforward. It's very much case
No
by case
pain, no
basis.
gain. We've said this, okay?
They drill that home.
So what are some? So I'm always surprised, honestly, when I reach out to a specialist, orthopedic specialist, for certain fractures that they're actually not emergently operable. They're not going to take you right away to the OR to do surgery. And it when I kind of first started, training and practice, it actually kind of threw me because partially on TV, partially because you think, oh, well, this is really out of place. We should go to surgery like now. And the answer is not really.
Yeah. No, a lot of times that is the case. I'd say the majority of the times, even fractures that look really bad, especially if you have a fracture dislocation in the emergency department and it can get reduced adequately, meaning it could be realigned close to normal anatomical position, more times than not, that will be sent home, and then there'll be a scheduled surgery, short of any like immediate nerve damage or things like what's called compartment syndrome, like too much swelling in a confined space or anything like that. It can often be done on an outpatient basis for a large majority of these fractures.
So let's say the ER doctor is an idiot and he can't properly align the joints. Like maybe the joint is kind of like this, and maybe he's kind of like, it's like this. What is considered acceptable as far as alignment goes versus, nah, you're an idiot, we should take you to the OR?
Even that, and I don't mean, it sounds like I'm trying to avoid answering the questions by saying it's an on individual basis, but it really is, because whatever, we'll take a random body, like a wrist, right?
Mm-hmm.
You know, if you get a distal radius fracture and you can align it really well, meaning like in the emergency department, we reduce it and it's in good alignment. Some of those can completely avoid surgery if it's a good alignment, depending on.
So you're saying if the ER doctor is competent, they can avoid surgery. That's
100% on a.
awesome. All right.
Even in the best hands, some of these can't get reduced adequately and will end up needing surgery. And even if it's perfect reduction, some of them will still end up needing surgery, depending on, is it your dominant hand? Is it your non-dominant hand? What do you do
What do you do with your hands? What do you do work? Yep.
Yeah. How old are you? Are there any potential nerve issues? So yeah, it's very dependent on the person.
So you have, let's say you have a fracture that's non-operable, right? It's, it's minor, you don't need surgery, but you're in a cast, you're in a walking boot. What's the typical timeline for getting that cast off, getting that boot off, going back to doing what you normally do?
So again, it would depend on how bad of a fracture it is, and you said non-operative, right? So we didn't have
non-operative. Yeah, surgeons look at this and going, what? It's a crack. It's fine, but we should probably put a cast on.
Yeah, I mean, so like the minor fractures that are non-displaced, it's not weight-bearing, things like that, you can generally assume it's going to be like the 4 to 6 week turnaround, generally speaking. And lots of things will factor into that. Again, individual basis. How well do your bones heal? How well do your bones heal?
That should be a key word for this episode, man. Well, it's individualized, All right.
I can avoid answering the question.
So I don't cast people in the ER. First of all, should I? Is my practice of not putting a cast on somebody for a fracture or a break, whatever, is that correct? Or should I be, casting every bone I see?
No, you are correct, sir.
Oh, thank God. I may be nervous there. I didn't know the answer to that question, actually.
Been mismanaging us for years.
Shit.
No. So we splint frequently in the emergency department, right? So you can think of that as like a partial cast. So a lot of times it's material called like a form of plexiglass that we will use. And the reason that we do that is because after fractures, there is still going to be potential swelling that occurs outside of what we see in the emergency department. So if you put a very restrictive cast on somebody and all the ankle or leg and that swelling keeps going on, but your cast is very tight, that can cause nerve damage, vascular issues, compartment syndrome. So it's a good thing to splint it initially, and then they get seen by ortho, and then if ortho thinks it needs a cast, they'll cast them a few days out when the swelling is minimized.
And that's mentioned, the second time you mentioned compartment syndrome, and you mentioned nerve and vascular damage. So compartment syndrome is a real emergency. That's when, you're calling the orthopedic surgeon, plastic surgeon, whoever, to come in and be like, hey, this is an issue. So what is that? Obviously, we can see it. You mentioned, we have a cast on there, swelling, restriction, negative compartment syndrome. What's going on, let's say, in like the forearm here?
Sure. So you could think, your forearm, it can only expand so much. When you have a fracture, you have inflammation, bleeding going on, things that cause swelling, and that area will keep expanding, but there's only a fixed amount of expanding that can be done before it starts causing permanent and limb-threatening complications. And some of them, like you mentioned, are nerve issues, vascular issues, and it is a medical emergency if something like that happens and the pressure of your compartment gets too high.
And to measure that, we have a nifty little device called a compartment pressure check. I don't know if there's a factual name for it. Stryker. That's right. The Stryker needle. Yeah, I think it's a brand name, but I'm not paid by Stryker, so it is what it is. But we take the needle and basically it goes right into like literally the meat of that forearm, we get a number that says, oh, that's a problem. Now, the question is, how do we treat that?
That is emergent surgery. That will need what's called a fasciotomy, and you will need that is one of the things that orthopedic surgery will usually orthopedic surgery.
Mm-hmm.
Some of our trauma surgeons will manage it too. It very much depends on the hospital, but oftentimes it's orthopedic surgery, and that is something they will emergently come into the
Yeah.
hospital for. That is not something that can wait until even the next day. If there is
And it's
compartment syndrome, it's going to the OR.
and it's not inherently obvious either in many ways. Like
No.
I had a patient. So okay, story time, right? First month out of residency, I'm in my practice. I'm like, all right, I'm doing the real deal now. It's the weekend. It's a Saturday. So first of all, you have to understand, nobody's working on a Saturday. Okay, the hospital is dead. Admin's not there. Your specialists aren't there. It's really like me and the internal medicine people. That's it. So I get a patient who comes in, literally had something just come down, crush injury, just heavy block, heavy machinery, whatever it was, come down, smack him on the forearm, and he's sitting there, in pain. And I go and look at him, and all right, let's get an X-ray. It's like, all right, well, great, there's no fracture, and his pain's getting worse, and it's kind of like, all right, so let me kind of like bend the okay, so this is a problem now because one of the things about compartment syndrome is obviously the pain out of proportion basically to the injury. So there's no apparent injury. There's no cuts, there's no scrapes, there's no broken bones, but turns out he actually had swelling underneath his skin there. And I called the plastic surgeon. I basically was like, hey, I got a compartment pressure reading of, I don't know, 30 something or whatever it was. And he basically, like, before I finished my sentence, he was going into his car and driving to the hospital.
Oh, that's great.
It's like,
That's a
all
good
right.
doctor.
Yeah, that is. And they took him to the OR, and when they opened the skin up, they actually saw a significant amount of bruising inside there that had either the patient waited a little bit longer to come in, or I waited longer to call him, or if he was golfing or something, I don't know. They probably would have lost sensation and like had some nerve damage in his arm.
Absolutely. Yeah, no, that's a great catch. And that is, like you said, it's tricky to catch because the first sign is severe pain, and we expect pain with injuries, right? So the question is, what sets off your alarm, and how do you know it's not just a fracture? How do you know that it's the compartment issue that's the reason they're in severe pain? And it needs to be on your differential, and it needs to be something to look out for all the time.
Right. And, to be fair, we're saying not all swelling is compartment syndrome either here. Somebody whose, leg blows up because there's a sprain or something like that, that's not necessarily compartment syndrome. That's just swelling from the injury. But if all of a sudden you're kind of like, you have significant amount of pain, a little swelling, but you're like, yeah, I can't really move my hand here. Something's weird. Might be a red flag.
Yeah, exactly. If you have, like you said, swelling is expected, pain is expected. If you have severe pain and you take a dose of Tylenol or Advil and your pain significantly decreased, that's usually a good sign. Compartment syndrome is severe pain, and it's not usually subtle. So if you're just concerned, oh, it looks swollen, am I having compartment syndrome? But you're sitting there and you're eating and you're laughing.
Yeah.
It's probably not. You're okay.
We call it the positive Cheetos sign. It's like, okay, if you're able to kind of like sit down and, munch on a bag of Cheetos, and it's probably not compartment syndrome. It might be a fracture or a sprain, but it's not that thing. All right, excellent. Oh, good shit. That's some good information. What do you think? Any random thoughts or anything about we've touched on?
No, you funny because you were sharing a story, and it made me think that I wanted to share a story earlier when we were talking about, when you're saying, how do you know when there's a fracture of an ankle versus a sprain? And I just recently, this isn't a HIPAA violation because it's about my mom. It's about my mom, and I'm sure she's okay with me sharing this story.
Did she give you permission to share this story?
I'll get her to sign a release before you put this episode out. My son had a birthday party recently, and it was at one of those indoor play places. My mom went down one of the indoor slides with one of her grandkids, and she stood up and she just felt a crack. I got sudden severe pain in my foot, and I was distracted, like helping out with the pizza, getting the party, and by chance, so my mom, obviously I am my mom's son, but her other son is a physical therapist, and both of us are there.
Okay.
And she's like, all right, I guess I'm in good hands. And I look at her, and she's got tenderness by her lateral malleolus, and she's got tenderness by the base of her fifth metatarsal, which, as we were talking about earlier, there are things that we look out for that imply that there's a likelihood of a fracture, that you would need an X-ray. And I'm like, okay, you're going to need an X-ray. No, there was no obvious deformity. She had good pulses. Her pain wasn't out of proportion. So I thankfully had a splint in my car. I ran, I got it. I splinted my mom right there. I ace wrapped her. We lifted her leg up.
Wow.
She came back to the party. She ate pizza without bearing weight on it. And then she got an x-ray the next day, and it showed she had a pseudo-Jones fracture and a lateral malleolus fracture.
Oh my God.
Yeah,
Oh my God.
She was in a boot for 4 to 6 weeks, like we discussed.
Okay.
Yeah, it's
So you normally just carry splints around wherever you go,
now,
just kind
now
of
I
like.
do. I said I'm like now everywhere I go, it's always in my bag.
Is that a splint in your pocket? Or you're just happy to see me, to be honest. So it's funny because I actually do have a medical bag of my own, and I keep splinting material. I even keep, IV starts, line start kits and fluids and whatever. I get to carry any of the good medication that I remember just Dirty Dancing. You're looking at me like you've never seen Dirty Dancing. I know you've seen Dirty Dancing.
Swear I haven't.
Oh, Jesus Christ. All right. Anyway, so there's something happens basically, and one of her, friend of a friend kind of thing needs medical attention. Her dad is a physician, and, this is technically taking place back in like the, I don't know, 60s or 70s or something like that. You see the doctor, grab his black bag and, like run to the scene and, takes a needle out, like kind of like draws something up and injects her, and then everything is all better. And growing up, I'm kind of like, oh, that's really cool. Now I think of it, I'm like, what the fuck did he actually inject her with? Like what? Yeah. First of all, she's probably, I think she had like an abortion or something like that, like one of these illegal abortions. So she's probably like septic. She's in pain. And all of a sudden he gives like a magic shot and she's like, it's going to be all better again. I'm like, what the hell is that? Get her to the hospital. But
so that's my Netflix.
There you go. Yes. Jared, thank you so much for coming on. Jared Passer, everybody. Again, emergency physician, sports medicine physician, operates a clinic, full-time ER physician, full-time dad, does it all, and again, is a hell of a lot better than me at this point. Jesus Christ.
How about that? So, thank you very much. I appreciate it. This was fun. So
good. I'm glad. Hopefully we can have you back on in the future.
Yeah, I would love that.
See. All right, that wraps up another episode of the JAFERD Cast. Thanks again to Dr. Jared Passer for joining me. We talked about the differences between sprains and fractures, when to use physical therapy and why it's important, and, of course, when to go to the ER versus urgent care. Pro tip, if your limit's hanging off at an unnatural angle, probably a good sign to go to the ER, despite the wait, mind you. If you enjoyed this episode, please don't forget to like and subscribe, turn on notifications. I love constructive feedback. This is a fledgling podcast. Any constructive feedback is welcome, and I do read the comments. This show is designed to help you, the viewer or listener, make good choices about your own health and to raise issues facing healthcare in general. You can leave your thoughts and comments below for those on YouTube, or you can email me at jaferdcast@gmail.com. If you're in the healthcare field and you're interested in being on this show to discuss topics in healthcare, please feel free to reach out as well. Nurses, EMS, respiratory therapists, anybody in the healthcare field is always welcome to come on, give their insight, give their opinion. As with anything, don't take my word for it. Do your own research, talk to your own doctor, and remember, at the end of the day, I'm just another fucking ER doctor. Make good choices, everyone. We'll see you next time, and because this is Nurses Week, don't forget to tip your nurses on the way out the door. Thank you.